And now we'll move on to, those are serum biomarkers, virological markers. I'm going to talk about immunological serum biomarkers from Dr. Kyong-Mi Chang from the University of Pennsylvania and the Philadelphia VA. And so I don't know what's involved in getting Kyong-Mi set up. Oh, perfect. All right. Then without further ado, of course, Dr. Kyong-Mi doesn't need an introduction here, noted immunologist, participant in the hepatitis B clinical research network that has gathered a huge body of information. And Kyong-Mi's done some of the cutting edge frontier research in this area. So perfect person for this summary and for the latest. Kyong-Mi. So again, please send your questions to the chat box, and I'll pick them up and ask them in 15 to 16 minutes. Thank you.
Hi, good morning, good afternoon, good evening, everyone. Can you see my screen?
Yes, yes,
okay,
but you have
great.
to advance the slides.
Great. Okay, so again, thank you for inviting me to participate in this workshop, and I really appreciated Dr. Testani's presentation. So I'll just start right in to talk about the overview of the presentation in terms of the background on HBV immune pathogenesis and some of the literature, I guess known literature in the immunological serum biomarkers, and really try to sort of focus on the serum aspect of it. Although I must confess most of the work that I've done really is on the cellular immunity and summarize towards the end. And so as far as the background of HBV immune pathogenesis, I think the sort of God's truth about HBV, I guess people think about, is how CD8 T cell is sort of the central player, the virus not being cytopathic. The immune response mediates both the virus control and liver disease. And as the CD8 T cells will recognize viral antigens or epitopes that are presented in the cell surface in a class 1 MHC mediated fashion, it will then either kill the infected hepatocyte or release antiviral cytokines that would non-cytopathically cure the hepatocyte. And that requires coordination with CD4 T cell, of course, dendritic cells, and the B cells making neutralizing antibody and perhaps some other roles that we're not yet fully aware. So that's the best scenario. On the other hand, in the setting of HBV persistence, we know that there is global and virus-specific adaptive immune dysregulation. And that's through a multiple mechanisms, certainly PD-1, CTLA-4, and variety of immune regulatory pathways.
Kyong-Mi, I think your slides are not moving. Sorry to interrupt.
Slide one. Yeah.
Thanks.
Okay.
Maybe if you put on display mode, that would be better if you put them on display mode, because right now they're on the working mode.
Yeah, it's on a display mode.
Okay, well, we don't see them this way. Let me see.
Okay, let me see.
We see just the overview of the presentation slide.
I see. I'm sorry.
Oh, you
okay,
got,
now
it's just good now. Thank you so much.
That's strange.
Yeah, it's fine. It's moved.
Can you see it now?
Yes.
Now I have a display.
Background HBV persists with global and virus-specific adaptive
Perfect.
immunity.
Okay. So can you see this now?
Yeah, we're seeing your slide number 4.
This is slide number 3. Huh. I see. So probably I cannot do display. I just have to show it separately. Okay. I don't know why that is, but okay. Can you see it now?
Yes, absolutely.
Great. Okay. So this was the background that I was trying to show you for the CD8 T cell effector response that would either kill and or cure the infected hepatocyte with help of other adaptive immune cells as well as innate immune cells. And in the, did that move?
Yes. Background
Great.
HBV persists, slide 4.
Thank you. Thank you. All right. So global and virus-specific adaptive immune dysregulation, and there are a variety of different pathways, such as the inhibitory receptors, PD-1, PD-L1, CTLA-4, as well as BIM in terms of suppressing the T cells, deleting the T cells, also regulatory T cell cytokines and chemokines, suppressor cells, arginase, metabolic deficits of exhausted immune cells. And of course, the circulating antigens do seem to play a role in perhaps leading to promoting viral suppression through immune dysregulation, and perhaps the duration of the infection appears to also impact that response. But the issue with chronic HBV, one question that one might pose is that with this blunted adaptive immune response, what causes all the dynamic changes that we see in chronic hepatitis B with fluctuations in ALT, HBV DNA, E antigen, S antigen, and other viral biomarkers, and of course, ultimately disease progression. So the question there is, in the presence of the adaptive immune dysfunction, there may be viral persistence with differential immune activation and regulation in the liver. And I think the idea here is that lack of leadership, as we might see in real life, could lead to perhaps activation of other pathways. Here, looking at innate cellular activation with inflammatory and regulatory effects, Kupffer cells, dendritic cells, NK cells, gamma delta T cells, platelets, all these other cells may actually play into the chronically HBV infected liver in contributing to either inflammation or control of disease, MDSCs, Tregs, and others. Now, this some of this example would be with the HBV, the dendritic cells and Kupffer cells may produce interferon alpha, IL-8, subsequently leading to inflammatory NK cells that would then target the hepatocytes that would be upregulating trail receptor through the IL-8, thereby leading to hepatocellular injury. Also knock out some of the activate antigen-specific T cells. And again, there are lots of different cells that contribute, whether directly or through secretion of different cytokines. So our goal is to really look at the serum biomarkers, since it is very challenging to look inside the liver. So a number of different soluble inflammatory and regulatory factors may be relevant, such as cytokines, chemokines, and metabolic factors, as well as other regulatory factors. So one interesting thing to think about, I guess, is that, does it make sense to look for immunologically based biomarkers in serum rather than the liver to correlate with HBV outcome and therapy? And here sort of maybe perhaps as a not really a joke, but I think this is something that we actually think about a lot. We go to the moon, but nobody really actually goes. We read about it. There is Everest, we hear about it. We don't actually have to go to the New York Stock Exchange. We can check the apps. And so the idea is, can we truly get a good understanding of the liver by measuring effects in blood? So I think this is both our challenge and opportunity. And I think this is still an evolving work, some of which I will try to describe. So what can we measure in blood? Understanding that there is a whole lot of activities going on inside the liver as the portal vein and hepatic artery goes through the liver and dumps out into the hepatic vein. The idea is that there would be a lot of different, of course, viral, but also immunologically based biomarkers that would actually be circulating through the blood. And so, of course, this is about serum, so I will not discuss about the circulating adaptive and innate immune cells, and certainly findings in those cellular phenotype and gene expression and function have shed some light on what is going on clinically. But again, serum markers in terms of cytokines, chemokines, regulatory factors, and metabolic factors. So we can start maybe with some of the published literature in the chronic Hep B clinical course. And just to summarize some of these factors that I will review in this talk. So I think this is actually a great example of sort of pathogenetically relevant measure in the blood that actually helps us understand what may be happening inside the liver. So this is looking at, as HBV DNA and ALT fluctuates, there's also similar tracking of serum interferon alpha and IL-8, as well as increased trail expression in CD56 high NK cells that track again with the ALT elevation. And it looks like interferon alpha, in fact, increases trail expression in NK cells, and IL-8 increases trail receptor 2 expression in HepG2 cells, which will then be examined in the HBV-infected liver with increased trail receptor 2 expression, and NK cells from chronic HBV patients can mediate trail-induced apoptosis in the hepatocytes as opposed to the controls here. So it indicates that there are measures such as these serum cytokines or chemokines or inflammatory mediators that one could measure that can give us some hint of what is going on inside the liver and what may be pathogenetically going on. Another marker is IP10 or CXCL10, which correlates with hepatocellular injury, T-cell activation, viral DNA, and HBs antigen. Here, one study shows that the serum ALT has a nice positive correlation with serum IP10 as well as PD-1 expression in CD8. Here is looking inside the pathological hepatic activity index, and there's a significant positive correlation as well as, again, with ALT activity in a different study. But pointing to perhaps an antiviral mechanism, there's an inverse relationship with HBV DNA and HBs antigen. So it seems that the IP10 as an interferon gamma inducible protein is correlating with hepatocellular injury and T-cell activation, but also with potentially antiviral activity. And this is looking at additional chemokines, CXCL9 to 11, as well as IDO or indolamine 2,3 dioxygenase. And these chemokines, of course, can be made from many different cells, including hepatocytes and sinusoidal endothelial cells, and have a role in recruiting a variety of other immune cells. And IDO is inducible in epithelial cells and dendritic cells by the cytokines, again, with regulatory and antiviral activities that have been reported. So in this study, again, that's showing how these serum CXCL9 to 11, but not interferon gamma, IL-10 or TNF alpha in this study, I'm not showing the data here, was increased in patients with chronic hepatitis B with flare compared to HBV chronic hepatitis B without flare. And also CXCL9 levels in chronic hepatitis B correlated with ALT here and IDO activity. And there was an increased IDO activity during ALT flare in chronic hepatitis B, and co-culture of the NK cells with PDCs enhanced IDO activity and suppressed HBV replication in vitro. Again, indicating that perhaps that these markers can be correlated with what's happening in terms of hepatocellular injury and different immune activation. More on the metabolic side, perhaps, or rather this is serum L-arginine is reduced due to increased arginase activity in chronic hepatitis B coinciding with increased serum ALT activity. First, here is showing that serum L-arginine is depleted in chronic hepatitis B with ALT elevation above 100. And also that arginase activity is greater in HBV positive than HBV negative liver, arginase being something that can be released by a variety of cells, including injured hepatocytes, as well as endothelial cells. And ALT flares in chronic hepatitis B coincides with increased serum arginase activity, once again, perhaps reflecting the hepatocellular injury and release from the liver. And the L-arginine replenishment restores CD8 T-cell proliferation in vitro, as you can see by CD3 zeta here, and also the cellular proliferation by CFSC, and expansion of antigen-specific CD8 T-cells. So these arginase and L-arginine may be a key regulator of immune capacity, and that also relates to hepatocellular injury. Another marker that has been recently looked at, certainly PD-1, PD-L1, it has been actively investigated in the cellular immune response, but the soluble marker also has been looked at. And this is one of the studies that actually has done that. And there seems to be certainly a significantly greater soluble PD-1 level measured in HBV patients that also may somewhat differ between immune active and inactive carrier and immune tolerant, as well as a gray zone group that didn't really into any group, but I think the key difference might be these right here. And also soluble PD-1 level correlated with different fibrosis markers such as and as well as ALT, AST, bilirubin. But as one would expect with fibrosis progression, there is a negative correlation with platelet count. And importantly, PD-1 levels, the soluble PD-1 level was significantly different also with histologic inflammation. Marker that could be potentially considered. Now, moving on to outcome of antiviral therapy. Again, very similar markers have been examined in different published studies, and they show correlation with HBs antigen decline during nuke therapy. Here is IP10. And what we can see here is that the IP10 level is significantly greater in individuals that at baseline, in individuals that actually had more than a half a log HBs antigen decline. And also IP10 level at the virological response, the virus is dropping, that also significantly correlated with the amount of HBs, the group that actually had greater HBs antigen decline. So again, similar to what's happening in the natural history, there seems to be some potential role of IP10 in predicting perhaps HBs antigen decline. Still more on the IP10, the drop in IP10 levels seems to be much more significantly detected in the responders compared to the non-responders. And also, as you can see, tracking over time during therapy, the HBV DNA decline, E antigen decline, and S antigen decline, it's much more profound in the individuals who have per ml of IP10. So it seems to sort of differentiate individuals who have a greater virological response on therapy, and this one is in pegylated interferon. And another study showing the similar thing, essentially that E antigen decline is much steeper in individuals who have IP10 levels that are higher at baseline, again here on pegylated interferon alpha. There are also other chemokines that people have examined, and again, really here looking at CXCL and IL-21, the acute and chronic hepatitis B, and what they was resolvers in acute hepatitis, but not in non-resolvers, and chronic HBV patients with nuke followed by pegylated interferon alpha therapy in the individual who actually had suppression of HBs antigen showed the rise in CXCL13 and IL-21 suggests the control of HBs antigen. And of course, this is a single patient, so difficult to really make extrapolate to greater number, but an interesting observation. So monocytes or macrophages are certainly something that's plentiful inside the liver, and soluble CD14 is shown to be increased here in patients who have undergo pegylated interferon therapy at week 12, and is shown here. And the full change in the soluble CD14 seems to be somewhat correlated with HBe antigen loss, although I think the difference is really a lot of overlap, even though statistically significant. And I guess the confusing part for the soluble CD14 is that in a group that's combining HBV and HCV patients with cirrhosis progression, it was actually a higher level and more correlated with individuals with cirrhosis rather than not. So I think certainly a marker of monocyte activation and maybe worth evaluating, but I don't know exactly what its significance it is right now. So back to this schema, I think one can say that there is adaptive immune dysregulation through multiple pathways with activation of innate immune system and inflammatory responses and hepatocellular injury. I think there is a question about whether, immune activity as a way to describe chronic hepatitis B is accurate or not. And I think it's an evolving question, and I invite questions along that line. But I think the clarity that we have to have is what is really immunity and what is inflammation when they're all involved in the same process. Perhaps in the presence of functional adaptive immune response, one have a more coordinated response that could be considered immunity, where inflammation ensues in the absence of that correlation. So in summary, in the future direction, really numerous immunologically based serum biomarkers have been examined with correlations to clinical status and treatment outcomes. Despite their rationale, though, I think it's whether it has truly clinical utility or not, I think isn't really clear to me upon my review beyond the clinical and virological measures. So I think there's further studies that are needed. And also, in my mind, even though we can read about it, we can hear about it, we could use apps, perhaps being able to evaluate the intrahepatic immune environment is a very critical piece of what we can do. And so here I would like to pause and thank you for your attention.
Thank you, Kyong-Mi. Great talk, great summary, and obviously the immunological serum markers are the frontier. There are a number of questions coming in, but I'm getting pressure to move on. But let me ask a couple of the questions that have come in reverse order. From Malamani, he asks, and by the way, I'm not going to ask my questions because I'll catch you here in Philadelphia. Do you think there's a place for more unbiased studies for serum biomarkers in HBV treatment studies using broad metabolic and proteomic screens? So a short answer, please.
Yes.
I figured, and not your last slide. Kind of.
I did a metabolomic slide, but then I realized, well, maybe it's not really immunologic, so I deleted that. But thank you, Mala, for asking that. But of course, yes, absolutely.
And then this one actually is going to will open up more questions from Ahmed Eisenquari. Given the central role of CD8 T cells in the immunopathogenesis of HBV, why is a B cell therapy, rituximab, the drug most associated with HBV flares? I know you can. But I have questions.
Well, I think that's probably still an unanswered question. I do think it's a fascinating question, and what we're realizing is a lot of B cells in the liver for sure, and so certainly more to come on that. And I should probably let the next speaker go.
Well, there are a lot of other points you can make, but I really want to thank you. These are obviously the frontiers, Barbara and Kyong-Mi, in biomarker. I'm going to turn this over to Dr. Ulla Protzer, and pointed out that some people are asking questions through the Q&A box, and we'll try to check that. But please ask questions in through the chat box. But thank you very much, and Ulla, to you. I'll enjoy listening to the rest of the talk.